Well, the current need is to help identify what the volume outcome relationship of mitral valve surgery for primary mitral regurgitation is, define that, but also assess overall volumes, and we use the United States as the reference. So this was an analysis of the Society of Thoracic Surgeons adult cardiac surgical database that examined initially 125,000 patients performed over 3 years. And then after excluding for mitral stenosis and redo surgery and etiologies that were not primary MR, we were left with a sample size of 55,300 patients done at over 1,000 hospitals. And then we looked at that volume and to see who was doing what. So first of all, we assessed the volume. So currently, of the 55,000 patients for primary MR in the United States, 81% of those were actually getting repairs. But when we subcategorize that into the lowest volume quartile versus the highest volume quartile, the highest volume quartile were repairing them nearly 90%, and the lowest volume quartile approximately 66%. In addition, in the highest volume quartile, nearly 40% of patients are being done now as a minimally invasive or robotic approach, whereas that's only about less than 10% in the lowest volume quartile. Now that's the general overview. However, when we then looked at outcomes and looked at the primary outcome measure was risk-adjusted mortality at 30 days. The secondary outcome was 30-day composite mortality and morbidity, such as bleeding, infection, stroke, renal failure, prolonged ventilation, as well as 1 year mortality and 1 year rehospitalization for heart failure or reoperation. Those were the volume outcome assessments. And there were significant findings with lowest versus highest volume quartile in 30-day mortality, 30-day composite, and 1 year mortality, but not in rehospitalization or reoperation. In addition, we studied an interaction term, so it wasn't the mitral valve replacement as the bad outcome versus repair. There was no interaction. So it was really a volume outcome association. So this data will help clinical practice as well as help future guidelines. We found an estimated true inflection point for quality of mortality and 30-day composite, as well as survival, as well as successful repair rates at the hospital level at about 70 cases, actually 75, and at the surgeon level at approximately 35 cases. So this helps define when one is looking for a quality program, what that should be. Heretofore, that's not been clearly defined. And so current guidelines are there to recommend timing and type of intervention, being valve repair, both in the United States and in Europe. And this now adds some clarity for the current guideline recommendations and likely future guideline recommendations. Sure, this data will help future research by helping this as a starting point. But the goal is to get better. And our goal is to help surgeons get better. Right now, what was very important to find is that currently there's innuendo and not the most robust data to estimate what those volume thresholds might be, much higher thresholds. Right now, in the United States, there are well over 300 surgeons that meet these criteria and nearly 150 hospitals that meet these criteria. So it's not 10 surgeons in the United States that can do mitral valve repair. There's a lot of competent surgeons, and that's important for access. And the same correlation will occur throughout Europe, that surgeons are getting quite good at repairing primary MR. We still have to get better, and we have to, as a global cardiovascular community, have to help everyone get better. But this also helps as we roll out transcatheter therapies and how we define mitral centers of excellence. Because one can't have a mitral center of excellence without both excellent cardiology and interventional cardiology and imaging and excellent surgery. So this helps define that better as we move forward in the innovative space of transcatheter therapies.